But I do want to bring our second panel up to the stage. We've heard about the who is on Medi-Cal. Now we're going to hear about what. What are the services that are covered and how are they provided? We've got two great panelists with us today. We have Deborah Kelch from Insure the Uninsured Project, and we have Jacey Cooper from the department. Please join me in welcoming Deborah and Jacey to the stage.
All right, good morning. So I'm Jacey Cooper with the Department of Healthcare Services. It's nice to be here this morning. So as mentioned, I'm going to talk a little bit about the what and the how. Medi-Cal is a large program, so we'll get into that. And I will be keeping it high level because it is extremely complex, but hopefully we can provide some information. So as mentioned earlier, there are two main deliveries of Medi-Cal, either managed care or fee-for-service. And I wish it were so simple to just say 80% of people are getting all of their services through managed care, but when we talk about what's carved out to a fee-for-service system, that becomes complicated, and we'll kind of highlight that a little bit as we go through these slides. But about 82% of our beneficiaries for their medical and surgical, the majority, the bulk of their services is in managed care. And that is done through 24 managed care plans across the state of California through a variety of delivery models that we will talk about in a little bit. And they're paid a capitation for those services, so a per member per month payment. And Lindy will get into those details for you later. The rest of our Medi-Cal beneficiaries are receiving their services through a traditional fee-for-service model. So a statewide network where they're providing services, or providers are providing services and being paid a fee-for-service. So those are the two main delivery systems in which Medi-Cal services and benefits are provided. And we will go into the details. This is also a chart just for some background in regards to the split of managed care versus fee-for-service across the years. So what's covered? And we'll start with what's covered, and then we'll get to how we do that. So we have what's called full scope coverage and restricted or limited scope coverage. And when it comes to full scope coverage, you're looking at all of your medical surgical benefits, for example, the preventive and wellness services for children under 21, that's where EPSDT would be included, your primary specialty acute physician services, inpatient, outpatient services, personal care. I won't read the list, it's there, but the majority of your medical services are going to be included, including behavioral health services, mental health and SUD services or substance use disorder services. Prescription drug and dental services are within the full scope benefit. Restricted scope or limited scope, you'll see there some of the populations that were mentioned previously by our colleagues. One of the things to think about when you look at the benefit will, how it's delivered is going to change based on the benefit. For example, specialty mental health service is carved out of managed care and into the mental health plan realm, where the counties oversee the specialty mental health services. And so that's where, if you look at it, someone coming into Medi-Cal, they receive a card saying, you're in Medi-Cal. Here's your managed care, say they're in managed care. Here's your managed care plan. But that's where the bulk of their services may be received, but they also have to coordinate with a mental health provider at the county if they need specialty mental health services, or a separate dental provider, or a variety of other things depending on other programs they may be available for or eligible for, like CCS, through a different delivery system. So just because you have the list of benefits doesn't mean all of those benefits are being provided by one entity. And that's one thing when you're wrapping your head around how Medi-Cal is delivered, understanding the benefits is important, but also how it's delivered across the state of California is also very critical. So we do this in a variety of ways. So benefits and how it's delivered we get authority in a number of ways. One is which is waivers. So I'll talk about this and then we'll go into the other part a little bit later. So we have 1115 waiver today. And I won't go into the bulk of the managed care benefits because we walked through that a little bit. But it's also where we currently or historically have had an opportunity to pilot or demonstrate things. So in addition to your core set of benefits that all beneficiaries receive and have access to, you also have an opportunity to pilot things or to look at ways of providing care different than we did before. And ways that we have done this in our existing 1115 waiver is whole person care. And you heard people talk about whole person care earlier, where you're focusing on a targeted population, usually high utilizers of emergency room or inpatient services, those in need of housing services or homeless individuals, and wrapping services around them that otherwise would not be provided through Medi-Cal. So that full scope list that CMS has approved, we're saying these are wraparound services. So services that wouldn't otherwise be eligible to be paid for by Medi-Cal. And CMS has allowed us to pilot and test if those services would allow us to improve care coordination, to reduce utilization, and otherwise provide a better benefit for our beneficiaries. And so lead entities, counties, and hospital systems across the state of California have been testing this for quite a few years. And the department is closely looking at this as an opportunity in the future. They've been looking at things like housing liaison services. They have been looking at recuperative care, respite care, sobering centers, and a wide variety of intensive care coordination for your most complex patients, those leaving incarceration, so post-incarceration bundles. Some really innovative things across the state have been tested, and we're looking at opportunities in the future of how we can think differently about how we provide care for our beneficiaries. You'll also see things like the Global Payment Program, and of course, many people in this room are probably familiar with our drug Medi-Cal DMS, so DMC ODS. So those are done in an 1115 waiver. 1915B waiver, so our specialty mental health program is done through a 1915B waiver. And then we have 7 in California, what are called 1915B home and community-based service waivers as well. And that's a wide variety of home and community-based alternative waiver, the assisted living waiver, the developmental disabilities waiver. There's a variety of waivers. And essentially what is happening there is someone who would otherwise be in an institution, a skilled nursing facility, a hospital, providing services that would allow them to safely reside in their community. So a lot of times they'll do waiver personal care services similar to IHSS, but a little bit different, and other services like respite or home nursing services to allow them to safely reside in their home and not in an institution. And those are provided through 1915C waivers. So you see we have a variety of waivers is what we call them. And this is where we're getting authority from CMS to provide the delivery system. So benefits come in a number of ways. Oftentimes these it's separate than just Medi-Cal eligibility. You also have to meet other criteria to receive certain services that may be in our 1115 waiver, 1915B, or 1915C, depending on what we're talking about. So when we're looking at a new benefit or new population that we are serving, we would look across 3 main areas. It's going to either be a state plan amendment, which is where we look for adding benefits or populations that require federal dollars to come into the state. Or we look at waivers. There are a number of waiver opportunities, as we just walked through, to see how we could leverage that additional financial funding and provide the appropriate services, like home and community-based services. And then if there is a state only, then we don't typically need federal approval for those things. It's a decision at the state where we use state-only funds. So that's a little bit about the benefits, how we get those benefits approved, how we build them, how we test them, and how we even wrap around services to the main benefit package in Medi-Cal through a variety of avenues. This is just to let people know, once someone's in managed care, and everyone who knows this, there's an exception to everything in California when it comes to Medi-Cal. There are 6 models of managed care. So it's not just you're in managed care. There are different models across the state. And this slide just kind of breaks down the different types of counties and what kind of model you may be in. And the easiest way to wrap your head around this is how many plans are in the county. So if you're thinking about it, is there 1 plan? Are there two plans? Are there multiple plans? And so it's the easiest way to think about it, but there's a lot of information out there for people that are interested in the different types of models, why they exist, and that piece, but I won't get into that today so we can focus on the other main pieces. So this next slide is probably the most important slide. In general, I think people can understand Medi-Cal, that we have a wide variety of benefits, but this is the one that I think is probably the most complex. And if you think about it, it's where the department is spending a lot of time and focus right now. You've heard us publicly talking about the fact that Medi-Cal is complicated. And we need to think about how we can better reduce that variation and complexity across the state. If you have been in one county, you've probably seen the benefit in how it's delivered in one county, because it can vary across population, it can vary across county, it can vary across plan, for a large number of reasons. But as I mentioned earlier, someone is in Medi-Cal, and they receive their services through the managed care plan, the majority of their services. But then here's a list of services that may otherwise also be carved out of that managed care plan. And those are systems that are overseen by a wide variety of people. Sometimes it's overseen by the Department of Health Care Services. Certain services are seen by the Department of Social Services. Certain programs are overseen by the Department of Developmental Services. So it just depends. And I think the one thing to also keep in mind is when you're looking at managed care, mental health, and dental, the majority of those are all actually, according to the federal regulations, managed care models. And that's important to think of because in 2016, CMS released the final rule, as we call it, for managed care. And it was probably the first time in a very long time, there are very clear rules around how managed care has to be delivered. Well, since the specialty mental health services are considered managed care services and meet the requirements of 438 regulations, there are a number of requirements that even county mental health plans must meet in the delivery of that service. So when we're looking across our services, even though things are carved out of what we call our main managed care plans, if you think of the 24 plans across the state who are providing services that many of you are probably familiar with, our mental health counties are also considered mental health plans and have to meet those same requirements. That includes things like network adequacy, time and distance, depending on the services. We're also looking at quality, performance metrics, grievance and appeals tracking, our expectations around quality of care. Those expectations go beyond not just your typical managed care plan that you may think of, but also our mental health plans and also our dental managed care plans. And that's a little bit different because it's delivered in two ways in California, just to make it more complicated. And so, if you think about this, we have some counties that have long-term care carved in, some counties who have long-term care carved out of managed care. And so one of the things that we're doing is looking across this variety and making sure that we're looking across the state and looking at opportunities for the future for our managed care entities and to ensure that our system is not too complex for a beneficiary, that when they get enrolled into Medi-Cal, they know where to go for what and how to receive those services. And when your system is complex as this is, that is a constant thing we are focused on. So I think the last slide is just a little bit about how we monitor that performance across all of those various delivery systems, benefits, and those types of things. So we do it in a number of ways, and almost all of this is on the department's website. But we look at performance dashboards by delivery system. So the main managed care plans, medical, surgical, have their own performance dashboards. The mental health plans, the specialty mental health plans have their own dashboards. Dental has their own dashboards. And then a variety of other programs that are carved out have their own dashboards. We do beneficiary satisfaction surveys to gauge satisfaction within the program and to inform future decision making. External quality review organization, what we all call as EQRO. There's a variety of reports and findings that they look across all of our delivery systems, performance measures and various quality metrics, and then of course monitoring grievance appeals and audits. So the system is large, it's complex, the benefits vary in how they are delivered. The benefits remain the same. It's how they are delivered in each county is really what's different, and whether it's into a managed care plan versus not. And I think the hard part for people to understand is just because it's carved in one county doesn't mean it's carved in another. And then we monitor that across the system. So to say it's complex is an understatement, but that is all I have for later.
Thank you.
All right, thank you.
So good morning, everyone. How you doing? Taking it all in? Can you pass the quiz, though? That's the question. So again, my name is Deborah Kelch. I'm the Executive Director of Insure the Uninsured Project, known as ITUP. ITUP, if you don't know about us, is a nonprofit health policy institute, and we basically have two streams of work. We do health policy research and communications, and we also do broad-based stakeholder convenings, including an annual conference, which just happened a couple of weeks ago, and I know many of you, or I've seen today, were there. One of the things we try to do at ITUP, and I'm going to put this as my goal this morning, is we try to do what we do in the health policy research and communication space, jargon-free as much as possible. So when you're talking about the Medi-Cal program, that's a pretty tall order, as I think you've already gathered this morning. One of the things that I like to say, maybe it's just because I've been doing this a really long time, and I appreciated Margaret bringing up the notion that Medi-Cal began a long time ago, and a lot of the decisions that we made were made then, but along the way, the program has really shifted and changed based on trends in the market, political compromise, fiscal challenges at either or both the state and the federal level. So I think it's really important when we look at this program to really think about the fact that context matters. I think pretty much anyone who's working on the Medi-Cal program at this point, if you look at the complexity we're hearing about, wouldn't say, let's do that. I think really it just reflects this evolution over time and decisions that were made that in the context in which they were made were what people thought were the best decision to make at the time. And I'll use one example, and that's the carve-out of mental health and addiction treatment services. So that resulted from the state's interest and the collective interest in doing managed care and Medi-Cal to address some of the challenges in fee-for-service, most notably the difficulty in getting services. And at the time, counties were the providers of mental health services and the very tiny amount of addiction services that were even available. And the broad array of what we think as mental health was not typically covered for Medi-Cal patients. And so the decision was made to carve out mental health and leave the counties with those services for people with severe mental illness, also because we had just done a huge realignment of state and county services. And we had given the counties fixed revenues to do certain programs, including mental health. So were we to have decided to carve it in, we would have had to open the whole realignment. So we didn't. So I think when you look at it now, it may or may not make sense to you, but I think it's really important as we go through all these different pieces to understand there's a story that can be told like that, really about everything in Medi-Cal today. Another point I'd like to emphasize is that, you know, beneficiaries really do have very different experiences depending on where they live. It's a statewide program. There are state standards, and I know everyone really works hard to try to ensure basic protections, basic standards are met across the board. But as a practical matter, it matters what county you live in because you might have a different type of managed care plan, as Jacey noted. You might also have a very different set of providers in terms of the number and the type. For example, if you live in a large metropolitan area with a big county hospital, you have one set of options for you. If you live in a remote rural community, you may be seeing the one community clinic or health center in that region. So I think we have to think about Medi-Cal as a state program, but we also have to really understand how different it is by the different counties. Also, I think when we look at Medi-Cal today, we're looking at a program with pretty significant growing pains. Excuse me for the allergy voice. We're looking at a program with significant growing pains. So this means that we're challenged to provide adequate access, adequate provider networks, and we're experiencing, not just in Medi-Cal, but acutely in Medi-Cal, really profound provider shortages in many urban centers, but also in these really remote and rural communities, where a lot of the expansion of coverage actually occurred. And when you have a program of this size in this time, we are struggling, I think, with everyone working really hard to do this, to ensure quality and consistency with the different managed care models based on what county resources are available, what kinds of providers are available, and a constant tension between local flexibility and statewide standards. So I just think if we have that as our, kind of one of our operating principles, that can be helpful. So what are, I'm not sure, I wish it would help, but thank you, Sandra. Sorry, it's just that time of year. So what are some of the issues that we face now? I like to just try to simplify and put them in 2 buckets. So it makes it easy, right? So one bucket for me is the federal changes and the federal climate and federal uncertainty, which we're all familiar with, even if we don't know all the details. And then another bucket is state-level efforts to expand, finance, and improve the Medi-Cal program. So I'm just going to touch briefly, in a painfully brief way, on some of these topics. So let's go back to Jacey's conversation about the waivers. So again, the federal government authorizes states, and it's in federal law, that we can apply for changes to the program if we want to do something creative, innovative, either through financing or program. So we do have a Section 1115 health reform waiver, and this is one of many. Our waivers began in the 2000s. So we've been having Medi-Cal managed care Medi-Cal waivers under Section 1115 for a long time. This particular one expires, it's Medi-Cal 2020, expires in 2020. So what's at risk or what's at stake? So we know in this waiver we have basically the basic authority for Medi-Cal managed care. We have safety net funding and payment reform through public hospitals and health systems. We have the drug Medi-Cal program organized delivery system, which let me just take a second and define that for you. So essentially, addiction treatment is not included in managed care plans, except for some requirements they have to assess the need. And so we have a program that covers addiction treatment services, known as Drug Medi-Cal. And then we now have these pilot programs that happen through this waiver, which are really oriented around organizing those services. They had not been previously in a managed care framework, and they are now, and really exciting things are happening with the Drug Medi-Cal program and the Drug Medi-Cal Organized Delivery System waiver, and I encourage you to look. CHCF has a great overview of some of the findings we have so far. And then we have whole person care, which you've heard about this morning, for people who are, bumping up against multiple systems of care. So maybe they're having experience with the corrections, with behavioral health, with physical health, with housing challenges. We have what's known as the Dental Transformation Initiative. And then we have the Coordinated Care Initiative, which has multiple programs for dual eligible, and some other long-term care programs are all combined into this really significant Section 1115 waiver. The thing is that the federal government recently has changed the rules around waivers, and so we face some challenges going into the next year or 2 years around being able to continue all the programs in the waiver exactly as they are, and will be all of us, the department leading the effort, with all of us thinking about what are the strategies we might employ to continue features of this program, even though the federal government has changed some of the rules around how they calculate the financial resources they provide and the savings that we have to demonstrate. So the other waiver that's important in these coming years is the Section 1915B waiver, which we've talked about. So this waiver basically establishes the mental health managed care program through the counties, known as the county mental health plans. And so specialty mental health services are those services for individuals with severe mental illness and children with serious emotional disturbances. So these are the folks who have the highest need in the behavioral health, mental health realm. So one of the things that's happened for that program is what Jacey mentioned around the new Medi-Cal the Medicaid managed care rule, which happened in 2016, and somewhat of a revision is being considered from 2018. But that was really the first major federal overhaul of managed care regulations in Medicaid since around 2000. But it has imposed a lot of requirements that everyone has been working to implement, including for the first time for the county mental health plans, including timely access to services, better consumer protections, standards for contracting, and discussions for, and so we have a situation where serious mental illness is treated through the county mental health plans, and mild to moderate mental health conditions are treated through the managed care plan if a person is enrolled in a managed care plan. So we've all been working collectively to identify the best approach to make sure that the person is where they need to be, that their needs are assessed, and it's really clear how they get services, and it's a difficult challenge between the two. Because the carve-outs are a challenge, as Jacey mentioned, the department took the lead last year and really has been engaging with stakeholders to try to think about this moment. I think that we're at a kind of a critical juncture in the program because the waivers are expiring, because we're expanding and continuing to look to the Medi-Cal program as a major source of coverage for significant numbers of Californians. So we're having conversations about the carve-out and what we might do as an alternative to the current system, which could include regional models. It could include bringing all of the mental health services into a managed care plan, including those for people with severe mental illness, or carving them all out, including for people who have mild to moderate mental illness. Or it could be that there's some state-level set of options that local communities could look to and decide in their own region what makes sense. So those are conversations we'll be having over the next couple of years. So I just want to say a couple more things about the managed care rule, because a lot of activity has been ongoing here in California to meet the new standards under the rule since they passed in 2016. One, because they're applying to new entities like Drug Medi-Cal Organized Delivery System and County Mental Health Plan, and because a lot of new things are applying to our existing Medicaid managed care plans. It's important because, like, this is always true, but I think this was one of those times where it was a particular challenge because we had in California a lot of statutory requirements for plans that are licensed in the state and serve Medi-Cal to do timely access analysis, make sure services are timely. We had strong standards around network adequacy. And so we had to do this kind of what's in state law, what's being required, and try to figure out what we needed to do here that would make the most sense and would also comply with the federal law. And there's a lot of other things in the Medicaid managed care rule, and I think it's fair to say we've made some progress, but there's still more to do, and the areas include beneficiary disclosures, care coordination, enrollment timelines and protections for beneficiaries, quality measurement standards, expanded data and transparency, both for the state and for the plans. So this is going to be on our radar screen as a continuing issue and continuing requirements on all of the players in the program. And then I would just like to say a minute about the fact that we have quite a few pilots and limited programs, which Jacey mentioned. And I think this is why I think we're at a critical juncture in this program, because we're learning some things about what works. That's good. We're trying some new additional things, also good. But I think it's a good time for us to have a higher level conversation, if we can, about what does the program need to look like to most effectively meet the needs of patients. And is it the right thing to have programs oriented around specific categories of beneficiaries? It might be. Or is there something about the program we could fix, add, revise that would make it work better for people in some way where we didn't necessarily need? And I think Margaret mentioned navigators, and there's a lot of conversation about all of that. Also, the department at one point noticed that it had the intention of going out for a procurement of the existing commercial plans who are participating in Medi-Cal. Also a huge opportunity to sort of think about, if you are asking the plans to compete and apply, what are the elements you want them to bring to the table for the Medi-Cal program today compared to when it maybe first brought them in. And the last thing to say, or well, it's not the last thing, but I think the other question about Medi-Cal that I can't even begin to touch on, but Medi-Cal is at the center now of all the conversations we are going to have, whether it's about Medi-Cal expansion of eligibility or big system changes where we're talking about things like single payer, public option, whatever the conversation is about universal coverage, Medi-Cal will be at the center of those conversations as both an option, an opportunity, and potentially a challenge. So lastly, I'd just like to say a couple of words about carve-outs. ITEP is currently working on an issue brief where we're looking at multiple issues that are facing the Medi-Cal program. That should come out in a couple of weeks, so I have a lot of these issues top of mind. The thing about carve-outs is they generally began because there was a perceived sense that there was a special expertise required. So the counties were serving people with mental illness, the dental plans, California Children's Services, which is a program for children with specific health problems and illnesses, are seen by counties who organize and provide for their care. So that was generally the reasons that carve-outs were done. But now what's true about carve-outs is that they frustrate coordination of care. They add complexity and barriers for the most vulnerable beneficiaries by definition, right? So the fact that you need to go to multiple systems defines you as a person who has a lot of health, mental health, and other challenges. There's a very inefficient use of resources. There's a lot of duplication, whether it's in assessments, contracts, standards, oversight, site visits. There's just a lot of overlap. And it also distorts the incentives, and I think this is a place we can all keep talking about. So I remember when I was first in the legislature, promising not to tell you when, and there was a discussion about managed care. And the person trying to sell my boss about it, who was the chairman of the Subcommittee on Aging, said, Senator, you'll be glad to know long-term care is totally carved out of this plan we have. And I was pretty young and pretty new. And in my head, I thought, well then, won't the plans just have an incentive to get people off to that nursing home when they start getting expensive? But it wasn't my job to speak at that moment. But I think there's a lot of distortions in what happens for beneficiaries by virtue of the carve-outs. So that's another opportunity, I think. All of these things that we're talking about are great opportunities to look at the program in this time, look at the beneficiaries in this time, our care delivery systems in this time, and try to find the solutions, the models, and the opportunities that really will serve the beneficiaries. Happy to take questions.
Thank you, Deborah. Well, thank you both. We have about 10 minutes for questions from the audience. Again, if you have a question, please raise your hand and someone will come to you with a microphone. I would like to exercise moderator's prerogative, though, and ask the first question. Deborah, you mentioned the movement to managed care a number of years ago, and the impetus for that, I think you mentioned, were some of these access challenges in the fee-for-service program. Jacey, you touched on some of the accountability measures and metrics that the department is tracking. Can you talk a little bit about where you see variation, either in access or quality, and what happens then to a managed care plan if they're not meeting the department's threshold?
Sure. So, yeah, we have, I think in our main managed care plans, we've been monitoring these things for quite some time, as Deborah mentioned. And then more recently, after the final rule, started looking at also on the mental health plans, DMC ODS, and then the dental managed care plans. So the department looks at it in a number of ways. If you're talking about network adequacy, for example, there are clear requirements in state statute in regards to how fast someone has to be seen, the time and distance to various services, and the department undergoes annually a very detailed data analytics process with our managed care plans to receive all of the provider data, where they are within the regions that they're required to, and if there are any gaps or deficiencies. And if there are gaps and deficiencies that are identified where there's not an approved alternative access standard, for example, very rural areas sometimes can get an approved alternative access standard where we're utilizing more telemedicine services or other means of providing services to ensure access to services in those areas. If there is a deficiency, the department puts those managed care plans across all of the delivery systems under a corrective action plan. The plans are given time to meet the expectation, close the gap or the deficiency that has been identified. And if they don't, the department does have the ability to sanction the managed care plans, mental health plans, DMC ODS, or dental managed care plans to ensure that the proper access is met in a need. That same thing exists for our quality measures. So we have in our managed care plan, they're called EAS measures. We have a lot of names for acronyms for things, but a core list of measures, quality measures that we are evaluating all of our plans at, and if they meet certain thresholds or indicators, they are good, but if they don't, then we put them on a corrective action plan where they are required to do a large number of things. The department meets with them on a very regular basis to improve their quality, and if they don't have improved quality, the department does sanction our managed care plans for a lack of quality of care across the key measures that we are currently holding them to. I think in light of the final rule and others, we are looking at this very closely. We're looking across the state of where there are opportunities, where do we need to hold plans more accountable to ensure they're meeting the need to access and quality care for all of our beneficiaries. And of course, we post all of those things that I just talked about on our website in full transparency and disclosure so that you do know our network adequacy across all the plans, who's on corrective action plans, and whether they've met those corrective action plans. So that is all on our website so people have access to that.
Questions from the audience? Any questions from the audience? Yeah.
Jerry Jeffy, Public Health and Behavioral Health Policy Consultant. What is your opinion about having the law changed where Medi-Cal, it cannot be billed twice in the same day, the double billing, specifically cases like someone goes to a community clinic, intake, the primary physician says you need to get mental health services, we're down the hallway, but they can't be billed because of that restriction, and they don't come back, and that has a big impact on access. What about having that changed?
Sure, so I'm very familiar with what you're talking about. It's specific to FQHCs and the funding. So I think the one thing to remember, and I'm definitely not the expert on this, Lindy is, so she can weigh in later from the finance side. It's how it's currently funded today. So you have to separate. There's not a rule that beneficiary cannot receive those services that day, because the way the fee-for-service or the way the FQHC PPS rate is designed includes all of the costs for those services, including if they have both medical and behavioral health services. And so we do know that that has created some potential business or operational ways that Medi-Cal services are being provided in FQHCs, but the way that the rate is billed encompasses all services provided by that particular FQHC. And so We know that it's something that's talked about a lot, and we're looking at it, and we continue to look at it for the long-term benefits of our beneficiaries and how they can access services.
Just as a follow-up, from a practical perspective, if you're a provider or a patient that's seeking either mental health services or substance abuse services, what is the access, and what would you recommend for a community provider or a patient who needs those services?
So I think I understand your question. Is it just how someone can access mental health or substance use disorder services?
Right, how to locate within their community.
Sure. So if it's specialty mental health services, they would be going to their community health mental health program. They have full access, so they can come in, be assessed for those services with Medi-Cal, and same thing for substance use. I think this is where it gets a little complicated because, for example, if you look at mental health as a whole, in California, we have separated the mental health benefit into what's called mild to moderate services versus specialty mental health services. And so someone who needs more mild to moderate services, those services would be arranged for by their Medi-Cal managed care plan, where they are providing a network of providers who would be able to meet that need. If assessed, they would, and it's determined to be specialty mental health, they could be referred to the county program to be further assessed and provide services. And so it's kind of split in that way. And then also, as mentioned, we have DMC, which is statewide, drug Medi-Cal, but we also have DMC ODS, where it's voluntary for counties to participate in DMC ODS. So the benefit that's available to a beneficiary may be different depending on whether a county has opted into DMC ODS or not for the substance use disorder side of the benefit.
So just let me, I think everyone sort of acknowledges right now that we're struggling here with the two systems or three systems, depending on what's going on for you individually. You know, my thought about what's going on the ground would be, you know, the managed care plans may not be responsible to provide all the services, including those that are carved out, but they are responsible and have legal agreements with the counties to refer people to the services they need and to have the information at the plan level that beneficiaries need in order to access services. So rather than thinking of the individual trying to figure out where the county mental health plan lives, this is someone we already know by definition who's facing some personal, potentially significant challenges with their mental health issues or their addiction or whatever's going on for them. So I think, and I know the department emphasizes this with the plans in contract, but I think all of us need to just really get serious about making sure the managed care plans take their responsibilities serious and don't leave beneficiaries who are enrolled in their plan hanging out there because, oh, it's carved out. That's not acceptable. The health plans have an obligation to work with the counties, and the counties have an obligation to work with the health plans. And so I think if I was on the street somewhere working on these issues, I for sure would say, let's call the plan. They didn't answer, let's keep calling the plan. Oh well, let's call the regulator, the Department of Managed Healthcare, and see if they can help us get the managed care plan to do this. And that's the last thing I wanted to say, which is, in addition to the oversight of the Department of Healthcare Services, California does also require all of the managed care plans, except for county organized health systems, to have a license under the Knox-Keene Healthcare Service Plan Act, which covers many of the things that Jacey said, but also different kinds of things, including their financial solvency, including their arrangements with providers. And so sometimes that's an extra level of complexity, but I think most people would agree that having a separate regulator outside of the Medi-Cal program provides an extra level, we hope, of oversight. And so that's what I would say.
Deborah and Jacey, this was a wonderful panel. Everybody, please join me in thanking them for joining us today.